This is More Health, Less Healthcare, and I'm Peter Boland, hosting the last part of our series on what if they got the incentives right? And that's the question we should all be asking every single day. I want to lead off with a clear statement. Measurement in healthcare has a problem that doesn't get talked about enough. We measure a lot, we generate enormous amounts of data. We have dashboards and quality metrics and HEDA scores, star ratings and population reports all across the board. And most of it measures the wrong things, reports to the wrong audiences, and produces little, if any, meaningful change in what actually happens to patients and communities. And that's what I want to talk about today. The organizations in this episode didn't just measure more, they measured differently. They measured things that actually matter to communities, not just to actuaries and quality departments. They made their findings public and they held themselves accountable to what they found, even when what they found was uncomfortable for management. That combination, the right metrics, real transparency, and genuine accountability, is one of the rarest things in American healthcare. It's also the most necessary. So first up today is Meritus Health and their public dashboard. Meritus Health in Annapolis, Maryland built something that most health systems explicitly avoid, and that's a public dashboard with health equity and disparity metrics. Their leadership in Equity and Disparities Council tracks 6 goals, each measured by concrete indicators. I want to go over each one. First, increase diversity of leadership and workforce. Second, increase staff awareness of multicultural considerations and cultural observations. Improve staff comfort in asking about racial differences in care. Next, decrease disparities in care outcomes and community perception of diversity measured directly, not inferred. Now, you may disagree with what each of these are, but if that's the case, what are your equity metrics and how are you holding yourself accountable? That's a real question here. The public nature of the dashboard is really a significant move because it's not an internal quality improvement report, it's a public document. And when you publish your equity metrics, you're inviting scrutiny. You're saying, hold us to this. If the numbers don't move, ask us why. And that's a different relationship with the community, one where the health system decides internally if it's making progress or not. The Meritus also engages the community as a source of insight, not just a recipient of services. And like Presbyterian Health, which we talked about in the last episode, they understand that the community has knowledge that the health system simply doesn't, about what barriers actually exist and what interventions actually work, what the experience of care actually feels like for the people who don't share the demographics of most health system leadership teams. That's just a fact. That knowledge has to be actively solicited. It doesn't show up in the claims data either. Another example is University Hospitals in Cleveland and their zero defects policy as an explicit equity strategy. So what was this about? Well, under the University Hospitals leadership of Dr. Peter Provost, he applied a zero defects framework to healthcare quality. And that has direct implications for health equity investment. The premise is systemic. Identify and eliminate every low value behavior in the system, organized around 6 operational principles, namely, 1, create management accountability. 2, organize care around patients in primary care. 3, reduce mindless variation. 4, use data for continuous innovation. 5, hardwire upstream connections. And last, number 6, engage every level of staff. They applied the set of principles across 37,000 employee health plan members and 580,000 ACO patients, backed by real incentives. So what does this look like? Well, 0 copays on newer diabetes drugs, financial incentives for primary care physicians who completed 60% of wellness visits, and real-time performance dashboards visible to staff, not buried in a quality report. The results are some of the strongest in the entire series. Employee plan costs rose just 1% from 2018 to 2019, compared with 6% the year before. Medicare costs fell 6%, while the national average rose 6%, a 12-point swing. And this is really notable. Hospital discharges fell 15%. Skilled nursing admissions went down 31%. Length of stay fell 28%. Post-acute spending fell 32%. And emergency department visits fell 13%. And the share of benefits discharged home instead of to another facility climbed 66% to 85%. Now, these are really remarkable statistics, but here's the equity argument that Zero Defects model makes explicitly. The savings generated by eliminating low-value care are real money. They exist, and they can be directed. I want to underline what we mean by eliminating low-value care. That's a polite way of saying that activity, that care, should not have been rendered in that way. Now, Dr. Provenow's framework explicitly notes that savings of this magnitude could fund a hospital's upstream community health investment. That's not a theoretical possibility, it's a arithmetic reality. If a health system can demonstrate this scale of cost reduction through disciplined quality management, then they make the governance decision to route a portion of that reduction to community health infrastructure. They've just funded their upstream investment without requiring any additional revenue. The waste was already in the system. Zero Defects just surfaces it. And the question of what to do with the recovered resource, it's a governance question, not a financial one. We made the financial point, the money's there. And sometimes we hide behind this as a governance issue, which is easier to just go along with and it's a done deal. Well, it's not. This begs the question again, if such disciplined behavior on patient management can produce this level of savings and reduce unnecessary harm to patients at the same time, why isn't this job one of every CEO, every C-suite and boardrooms across the country? In my view, it should be, as a matter of professional ethics and stewardship, and frankly, responsible leadership. Why is such lack of clinical leadership permitted by every hospital board in this country? That is a key question to really wrestle with. Let's look at another very different example, the SCAN health plan, which focuses on prevention as fiduciary duty. SCAN health plan in Long Beach, California applies the measurement principle to one of the most resource-intensive populations in healthcare, seniors. SCAN's mission is to keep seniors healthy and independent, and that mission functions as an ethical foundation that shapes every clinical and financial decision the plan makes. The logic is straightforward. Upfront investment in preventive care means fewer expensive and unnecessary acute care services down the line, fewer emergency department trips, fewer extended hospital stays. And SCAN's benefit design And clinical interventions are organized around preventing disease, not just manage it after it has already advanced. And the results show up in the ratings that most matter in Medicare Advantage. For 2026, SCAN earned a 4-star Medicare Advantage rating across California, Arizona, and Nevada, in a CMS rating system that weights readmissions and care transitions heavily. The exact measures SCAN's prevention first strategy is built to move. And what makes SCAN notable in this context is that they treat prevention not just as a clinical strategy, but as a fiduciary responsibility. They can demonstrate and do demonstrate that preventive investment reduces downstream costs. So when your mission is to keep seniors healthy and independent, and your payment model rewards that outcome, then preventive investment isn't a charity, it's a competent plan management. I think that framing is important for the broader industry conversation that we really have to have. Prevention is often positioned as a values question. It's something a health plan should do because it's the right thing. SCAN treats this as a financial argument, and the financial argument wins every time. If you're willing to measure over a long enough time horizon, we're not talking 30 days reports and 90-day summaries, we're talking long-term horizon to really understand the extent of the investment and the financial return. So in closing, I want to go back to the basic tenet of what the accountability standard the industry really needs. I want to stress that what many of these case studies reveal again and again is that accountability must be the frame of reference at the member level, not just at the aggregate level. Not, we invested in food programs, rather, did this specific member's food insecurity status change? Did their utilization pattern shift? Did the intervention produce the outcome we were trying to produce for them in the first place? I know, we all know that the industry often hides behind aggregate data because it's easier to present favorably. Individual level accountability is harder. It's also more honest. And for the health plan boards that are serious about measuring impact, rather than just measuring activity, it's the standard that matters. Now, both are important, but member accountability is what matters most. So let's pull the thread through all 7 episodes because the arc matters. Episode 1 established that tying payment to outcomes changes behavior. Episode 2 showed that food is a clinical asset with documented ROI. Episodes 3 and 4 show that housing pays back returns, whether the institution leads or the community leads. Episode 5 showed that employers who act like rational health investors generate savings they can return to their communities. Episode 6 showed that asking communities what they need and then actually listening produces better programs and stronger trust. And episode 7, again, is where accountability comes in because all that investment, all that innovation, all that community engagement, none of it produces durable change without measurement, transparency, and the institutional courage to publish what you find. 3 principles run through everything in this series. Align incentives with health, pay for outcomes, equity, and stability, and not just volume of services. Treat social conditions as core infrastructure, housing, food, safe neighborhoods. These aren't add-ons. They're the conditions that either support health or undermine it. Put communities in the driver's seat. When local leaders and residents shape the priorities and define the metrics, the system starts serving the people who live there instead of the spreadsheets at a district headquarters. Meredith put the equity dashboard online. The university hospitals in Cleveland tracked waste down to a fraction of a percent, then asked what to do with the savings. SCAN demonstrated that prevention is fiduciary duty. And none of these organizations are doing anything that requires a policy change or regulatory mandate. They're doing things that require leadership, the willingness to say, hey, here's what we measure, here's what we found, and here's what we're going to do about it. So here's the thing about all 7 episodes that taken together. The most transformative work in the series isn't happening in Washington, it's happening in neighborhoods. A mother in Oakland faces different barriers to healthy pregnancy than a mother in rural Iowa. A senior in Pittsburgh needs different supports than someone in Southern California. I mean, no federal program, however well designed, can fully account for that variation all across the country. And the local collaboration between delivery systems, health plans, employers, and community organizations can, in every case in this series, accomplish much of what they set out to do. The healthcare industry has the resources to do all this as well. It has the data infrastructure to do this. What it has historically lacked is the incentive alignment to make it matter and the institutional courage to be honest about the gap. This is the gap that we keep coming back to between what it claims to value and what it actually funds and at scale. The organizations in this series, across all 7 episodes, have closed that gap, each in their own way. And the question for every health plan board, every hospital system CEO, and every employer benefit director listening to this series is, what's your reason for not doing the same? The case studies are in the book. The evidence, it's in the literature. The financial argument's been made. But what's keeping leaders, and particularly their boards of directors, from acting deliberately and at a scale on behalf of their communities as stewards of local health and community well-being? So thank you for listening to this series. I hope these takeaways have spurred some conversation and active listening and action as a follow-up. I'm Peter Boland, and this is More Health, Less Healthcare. Oh, first take, get it out.